We've left some time, happily, for you all to answer some questions since we have such an expert panel up here. And I have some in mind, but I want to give you all a chance to ask some questions if you have them. So, anyone?
So, question for Dr. Barrett. You mentioned that schools are the next big frontier for mental health, and I'm curious what specific things do you think schools need to have the resources to do that they can't do today?
Speaking to this, David? Sure, go ahead. So I would say a couple things.
Repeat the question.
Yeah, can you repeat the question?
Oh, sure. The question was, I mentioned that mental health is kind of the next big frontier for schools to be addressing, and the question was, what specific things can schools do to respond to that need? Is that correct? Okay. So there are a number of things. Personally speaking, we run groups. For example, I might see a group of boys and talk about coping skills or was with depression or anxiety, things like that. But I think the scale at which we need to be addressing these needs to be much more comprehensive. A large part of my job is still spent with evaluating students, so testing them, IQ testing, or going to meetings for pre-referral team eligibility meetings. So certainly I can't respond in the way that's necessary. So I do think it's partnering with more community support agencies to come in and lend their expertise in counseling. We do refer a lot of our students to folks in the community for counseling services, but I think it's a much more systemic organization that brings counseling services to schools, not necessarily provided by school personnel. I think that's probably the biggest way. I think the other thing is just working with fathers in particular about what mental health looks like for their sons or for their children. I dealt with a father a couple of years ago. The son had some significant anxiety, and the biggest issue was not working with the son. It was working with the father, that this wasn't about weakness or man up. It was about he can't help this, and he needs therapy, he needs counseling, he needs medication. So I think it's also doing much more education to families about what mental health looks like in a young boy, in an adolescent boy. But also, again, partnering with other agencies to bring those services, kind of going to a full service school model, that it's not just about reading, writing, math, but it's also the total social emotional well-being of the child. Hope that's helpful.
Right. I'll build on that. Just to quickly build on what Charles just shared. There's a key need in a school for capacity. Mental health clinicians available on site to service students. I see more and more organizations emerge that are looking to fill that need with the schools. As a principal, on my staff budget, I have money for a social worker, money for a school psychologist. Yet I have 59 students that we've already identified that are receiving either group or individual treatment or therapy. And there's not enough capacity in the school building to provide that. So we do look for partners. It is difficult to, we've had a hard time of connecting parents and families and students to outside organizations. So take your child to this office to get this treatment on this day of the week versus having in-house mental health clinicians available to pull students from class to provide that kind of group therapy for like challenged students or individuals. So I do see it playing out where the school is becoming more of the central location for some of the mental health work.
So I had a question that any of you are welcome to answer, but maybe Dr. Friedman-Hill, if you could start. Can you tell us a little bit more about the process of translational research and how we get from the kind of basic research that you presented into the practical application that we see in schools, for example?
Sure. So let me explain what is translational research. And then how do we get to mental health interventions that are school-based, or even distributing information to parents and teachers. So at the very one end of the spectrum, we have very basic research. That's research maybe in healthy individuals, research in animal models, trying to really understand just basic neuroscience. What translational research is to take it a step further. Once we understand more about the brain and neurotransmitters, structure of the brain, we can identify patterns which are disrupted. So what is the difference between someone who's typically developing versus children who are at risk or experiencing mental health problems? So the very first step in translation is really characterizing differences. And the next step is, once we characterize a difference, understanding those as targets. So the reason we want to understand what the mechanisms are is we want to target them for intervention. So the next step of translation is to come up with interventions. They could be pharmacological, they can be behavioral, they can be cognitive training, the things which will actually work on those targets and cause changes, which is one of the reasons why we're interested in tracking these changes with something like neuroimaging. Once we can establish that an intervention makes the changes both in the behavior of the individual and is addressing the biological mechanisms, then we're ready to move it into a clinical trial where we're going to look at efficacy, we're going to look at eventually how we deliver these interventions. So at one end of the scale, there's basic research. On the other hand, we have interventions and services. One challenge, I think, though, that I'm hearing from my fellow panelists is also we may do the research to show what are effective interventions, but that is different than having access to those interventions in the community. So children who are experiencing mental health problems, there's issues of where are they screened? Are they screened in school? Do they have yearly visits with pediatricians who are asking questions about development so we can screen for mental health? But also, where are they going for services? How are they going to pay for that? Where are services available to them? A lot of this actually moves into other agencies outside of the National Institute of Mental Health. There are agencies like SAMHSA and other community and state-based agencies, which one of their biggest challenges is how do we get those effective interventions into the hands of families that most need them.
Anyone else want to comment on that?
So at the Dream Center, how we address this is most of our services are provided for free. And what has happened through our community relationships is that we have people who come to us who have training or skills and saying, hey, I know there's something new and kind of know about your community here in Southeast. I would like to offer my skills, my gifts, my talents for you and your community for free. So this is how I think from a community standpoint, people are beginning to address this mental health issue, is that people are already doing it as practitioners, but because they can come here and they say, all right, I can share my time, talent, and treasure through this NCDC Dream Center. I want to do that, and this is how I'm best suited to do it. And we want that because we realize that this is the next frontier. So again, standing shoulder to shoulder with our schools and our community, we also want to be able to provide some additional help for the family and the child as well.
I'll just add one other thing, which is it's kind of a common sense idea, but it's also one of the most difficult, I think, that we've seen, and that is we need to reduce the stigma around mental health. We need to understand that health is inseparable. It's a single thing. It's not mental versus physical. You know, the brain and the body are both involved in all aspects of health, and the stigma that still surrounds mental health is a huge barrier toward people getting the services that they need. And it's a barrier for parents in developing an adequate understanding of their own issues or their children's issues. So as a society and as individuals, we all need to, I think, work on that.
Other questions? So many of you spoke about working with not just the children, but with adults, to understand the trauma that children are dealing with. And I imagine that behind that are a lot of adults who haven't been able to deal with their own trauma. Could any of you comment from your perspective on how you've seen that play out, and what either on a very small or large scale seems to work and kind of getting the message through to these adults who have an impact on their kids' lives?
I can share a couple things. People always ask me about how the kids are doing. I said the kids are fine. It's the big kids who really have the issues. Teachers, parents that really set the stage for what, or model for what children do. Children are resilient, but they still model what they see at home, what they see in school. So I think especially for young children, or you call it even elementary school, it's not so much always direct intervention with the child. You know, after they leave school between 7 and 3:30 or whatever the times are, they're still home with a parent, caregiver in the evenings, on the weekends, all summer long. So that person really is poised to do a lot more at times than what the school can do in our temporary access to the child. I think it goes back to the questions that we just spoke about, is connecting the family to a system of support that can not only address the child's behavioral difficulties or mental health difficulties, but mom and dad are not talking well, mom and dad are unhealthy physically, mentally, all of that in some way trickles down to the child. I worked in Baltimore City for a couple of years ago, and a bunch of boys in school, and almost in every instance, there was in some way, the child would tell me that their acting out behavior was a function of, I can't see my father. So before we intervene directly with the kid, that's not the kid's fault. It's the parent, the mom, the dad are not on the same page in some way, but addressing those family kind of systemic or more ecological needs, I think becomes the work of various providers that eventually have the lasting outcomes for the child in school or in general.
I'll also share a bit about our experience in terms of gauging parents and caregivers around these topics. I think as Charles just shared, it's very layered and nuanced when you deal with each individual student and their families. You have sometimes disconnect between the parents. What I experience a lot with especially our students that are most at risk is you do find that there's untreated mental health in some of the caregivers and providers, or you may find that the child has spent a lot of time bouncing around in sort of foster care. You also have a lot of times untreated substance abuse in the family and the caregivers, and that alone creates a very unique set of challenges to try to work through, when then also trying to increase awareness and support from the child's guardians. As it relates to the successes we've had, we over a course of a year developed a series of both morning and after school sort of workshops for parents of just our early childhood students. So we really wanted to target one cohort, and we wanted to go, follow the model, knowing that early intervention is at its best. And what came of those conversations were just parents having an opportunity to share about their experiences, express what their fears are, what their aspirations for their children are, and what they're dealing with on the day-to-day. And I think that alone created a little bit of more connectedness to the school, trust with the school, and as a result, we've been able to have some of those families agree to go through certain intake processes with some of the community partners, the mental health partners or social work services that we do have access to. It's, like I said, it's very nuanced, it's very layered and very tricky, but we have had some levels of success in getting both attendance and action for parents.
Yes, and I would say for us, what we have come to realize is that people will be a part of community whether it's healthy or not. So what we try to do is create environments where people are enticed and are welcomed in to where we are at 29 Pennsylvania Avenue, where the Dream Center is, and say, all right, we're going to have a mom's night out for single moms. So we're going to provide free childcare, a meal, and then we're going to bring in a guest speaker to help teach you about parenting skills, or maybe it's a pamper night and you're just going to have fun tonight, or maybe it's how to juice and what's the best way to do that. So bringing them into community and letting them share around their commonalities and also building on them is what we try to do in meeting those needs, because like Eric just said, it's very layered, and there's a lot of different players throughout each layer that do have connection with the family and the adults and the children. It's really trying to bring them together, and in creating environments like a mom's night out or like an after school program, people start sharing life with you. We then hear about these other players. And perfect example is being a mentor, invited into a council with a parent, a social worker, and then someone from the school. And it was like, hey, we want all of us to finally get together. I've heard about you, I've heard about the issues, so let's get together for the sake of this young man. And that's when you begin to start seeing the change, when everybody's kind of holding each other's hand and saying, all right, I'm here, I know you're here, and now we're actually going to work together for this individual. And like I said, it's one person at a time. So it is very time consuming, and I know we're a very result driven society, but I can tell you I've seen the results when you really are intentional with the one-by-one model. That's what it takes.
I just wanted to add a few words about trauma and neglect in early life experiences. So one thing that we know from research is that very early life experiences can have effects much later in life. For example, we know studies of children who were in large institutional orphanages when they were babies and toddlers. When you study them later on in life when they're teenagers, systems which are involved in emotion regulation, areas like the amygdala, and the connectivity with areas which are involved in emotion regulation are disturbed. They're not what they should be. They also may have problems with processing emotions, with their social relations with other people, with being able to regulate their emotions. And so one idea that I also wanted to plant was that very early experiences can cause stress, which have much later effects in life. But also we need to remember that the children that we are seeing today are going to be parents themselves, and we need a lot more research on how does your experience and how it shapes your social and emotional processing also affect how you parent a generation from now. There's also genetic effects when we consider families. So disorders like ADHD, there's real high heritability, which means that if you have a child with ADHD and problems with emotion regulation, they're very likely to have at least one parent who also has the disorder. And how does that affect their ability not only to follow up on interventions, but just their day-to-day life in the family?
You had a question?
So this is primarily targeted Mr. Clover, but anybody else is welcome to hop in as well. So you mentioned a lot about the one-by-one model, and it seems to work. Do you see, once you get to a certain point in a single community with that one-by-one model, that the community itself begins to do what your organization tries to do on its own? So if you get a certain number of people who have table manner skills, then it starts to spread throughout the school on its own.
Like a critical mass, and I'll just repeat the question is, by doing the one-by-one model, do you see happening, people owning what you teach and then thereby going out and being ambassadors for that? Yes, we do. But the thing is about in DC is that it's a very transient area where we are. So we will maybe have a child through the elementary age, but then they will go on to high school or junior high somewhere else throughout our city. And then so they might move, or they might move to Prince George's County. So it's very transient. So we realize that we don't have people from cradle to grave or anything like that. So we try to teach as much as we can with the time we're given, so that in the attempt of knowing that they're going to go someplace else and they need to teach this to someone else, we want to train them up for that. And as we begin to transform our community, so it's in our radius of where we are. We're in Ward 7, and there are a number of apartment buildings, again, increased transient nature of what's happening there. But also there's a generational gap. So there's a lot of people who live in Randall Highlands and the Penn Branch neighborhood who are senior citizens who are beginning to kind of age out. So there's a new generation of folks coming in and buying. So I'm seeing that we're going to have to keep doing this because there's new people coming, and it's very interesting to watch the changes in our community. But it's great for us because there's a school right down the street, 2 blocks away is Randall Elementary. So we have great access to a lot of youth right there. And so I would say, yes, we do train up people when we see that it happens, where people do take that out and be our champions. But we realize that they probably won't be in our community for long.
I think we take one more question, if there's one.
For Mr. Beth, what's your staff buy-in to what you're trying to get done?
So the question is, what is the level of staff buy-in to the work that we're trying to do around informing on trauma and responding to students, particularly our males? We're leading a large change process at my particular school, right, where a school is underperforming across a variety of metrics. And so there's a high rate of expected change and lots of initiatives that we're rolling out to staff at one time. So as it relates particular to this, the staff is becoming more informed. They are shifting their mindset from a lens of either sympathy or just not understanding to being much more empathetic and seeking the tools and skills they will need in order to appropriately respond and serve that community. So, but that shift is slow. In a whole year's worth of work, we're starting to see it play out in, say, teacher actions, teacher language, and that sort of deal. I believe the level of commitment is high, and I believe that everyone recognizes this as a landmark challenge for our school community to reach the levels of success we want.
Do you have resources to maybe do professional development things like that?
We do. We have resources. So, lots of those resources don't come by way of, say the district gives us a menu and says choose from these 5 great resources which one you want your school involvement. But they mostly come from really grassroots conversations. They really come from us seeking partnerships like the one we sought with Bank Street. They came in and worked with our early childhood families and teachers for a year. It looks like grant opportunities like the one we just wrote and submitted for a Males of Color initiative to get, I believe, $25,000 to then use towards professional development for teachers. So resources are there. Finding them and gaining access to them is a bit of work.
All right. Well, I think we're almost up on time. I just had a couple of other thank yous to close. I wanted to thank one of our key advisors, Dr. Jeff Evans, who's retired after a long career at the NIH, and we appreciate his support always, and especially for making the connection with ChildTrends so that we could have David Murphey here today. I wanted to thank Charlotte Armstrong for working with me on short notice to get Dr. Friedman-Hill here today. We really appreciate that. And Adam Buckaloo, who was until very recently working with Congressman Mullin on the Men's Health Caucus, who is now with the Energy and Commerce Committee, who introduced us to Ernest Clover. So I want to thank all those folks for making this possible. I want to thank you all very much for coming today. And looking ahead, we are planning to have a part 3. The series will continue, date and time TBD, but we are looking to have a discussion on adolescence in part 3 and perhaps a part 4 to talk about young adulthood. And so thank you all. Thank you, Tom. Thank you to the Congressman, to Congressman Donald Payne Jr., to Congressman Markwayne Mullin and the Congressional Men's Health Caucus. And I hope you have an excellent rest of your day and afternoon, and have a great weekend.